Modern medicine relies on algorithmic precision to eliminate clinical guesswork. The 2019 NICE guidelines for managing hypertension offer a deterministic logic tree for treatment. We are going to map exactly how this system works. In 2019, NICE updated the entry criteria for stage 1 hypertension. For patients under 80 years old, the threshold for pharmacological treatment dropped from a 20% cardiovascular risk score to 10%. The update also modified initial pharmacology. Angiotensin receptor blockers, or ARBs, were given equal standing with ACE inhibitors, allowing interchangeable use where indicated. But before any patient enters the pharmacological flowchart, there is a mandatory baseline requirement. Universal lifestyle modification must be maximized first. The clinical data on lifestyle intervention is specific. A BMJ study demonstrated reducing dietary salt intake by 6 grams per day can drop systolic blood pressure by 10 millimeters of mercury. This sodium reduction must be paired with specific behavioral protocols, reducing caffeine intake, stopping smoking, lowering alcohol consumption, and losing weight. Once these physiological variables are controlled, remaining hypertension requires chemical intervention. At this point, prescribing follows a sequential algorithm designed to maximize efficacy and prevent adverse reactions. To enter that algorithmic pathway, a patient must be accurately staged. This requires translating standard clinic blood pressure readings into their ambulatory or home blood pressure equivalents. This diagram shows the required mathematical translation. Stage 1 hypertension requires a clinic reading of at least 140/90, but to confirm the diagnosis, the subsequent ambulatory average must be at least 135/85. Stage 2 pushes the thresholds higher. A clinic reading of 160/100 must be corroborated by an ambulatory daytime average of at least 150/95. Severe hypertension bypasses the ambulatory confirmation. A single clinic reading with a systolic pressure of 180 or a diastolic of 120 triggers an immediate clinical response. For stages 1 and 2, relying solely on clinic readings carries a risk of misdiagnosis due to white coat hypertension. Ambulatory monitoring acts as a safety mechanism to prevent the administration of hypotensive drugs to normotensive patients. These numerical tiers serve as the primary diagnostic filter. They determine the exact point a patient crosses from observation into the pharmacological algorithm. Once a patient is staged, the algorithm checks for treatment triggers. For stage 2 hypertension, drug treatment must be offered to all patients, regardless of their age. For stage 1 hypertension in patients under 80 years old, the protocol requires a conditional assessment. Therapy is only initiated if specific risk factors are present. A stage 1 patient qualifies for immediate pharmacological intervention if they exhibit target organ damage, established cardiovascular disease, renal disease, diabetes, or if their 10-year Q risk score is 10% or higher. This graph illustrates a 2019 caveat for adults under 60. The short projection line is the standard 10-year Q risk score, while the larger expanding area represents their lifetime cardiovascular risk. Because a 10-year Q risk calculation can underestimate the lifetime probability of cardiovascular disease in younger populations, NICE suggests clinicians consider intervention for those under 60, even if their Q risk score is below 10%. Patients under 40 are excluded from the standard flowchart. They require a specialist referral to rule out secondary causes of hypertension before any standard prescribing begins. The intersection of a patient's age, Q risk score, and blood pressure stage dictates the exact moment pharmacological intervention begins. The moment intervention is triggered, we enter step 1 of the prescribing flowchart. The initial drug choice is dictated by demographic logic gates. The diagram maps 2 primary pathways. The left path captures patients under 55, or patients of any age who have a background of type 2 diabetes mellitus. These patients are prescribed an A-class drug, an ACE inhibitor or an ARB. If an ACE inhibitor induces a side effect, such as the characteristic dry cough, the angiotensin receptor blocker is the mandatory alternative. The right path of the flowchart isolates patients aged 55 and older. Their prescribed starting point is a C-class drug, a calcium channel blocker. This right-hand pathway also applies to patients of Black African or African Caribbean origin, regardless of their age. This demographic routing is based on clinical evidence showing that ACE inhibitors have reduced efficacy in patients of Black African or African Caribbean descent. Step 1 initiation is a choice between an A pathway and a C pathway, determined by the patient's physiological and demographic profile. If blood pressure remains uncontrolled on Step 1 monotherapy, the algorithm escalates to Step 2, adding a second agent. For a patient already taking an A-class drug, Step 2 requires the addition of either a C-class calcium channel blocker or a D-class thiazide-like diuretic. Conversely, if a patient started on a C-class drug, Step 2 adds an A-class drug or a D-class thiazide-like diuretic. The 2019 NICE update broadens these combinations. Previously, only a calcium channel blocker was recommended as the second agent for those on an ACE inhibitor. Now, a thiazide-like diuretic is considered an equal option. There is one demographic exception at this stage for patients of Black African or African Caribbean origin who are currently taking a calcium channel blocker. If these patients require a second agent, an ARB is the preferred choice over an ACE inhibitor. When dual therapy is insufficient to reach target parameters, the algorithm initiates Step 3, the culmination of the core flowchart. It requires the concurrent administration of all three major drug classes, creating an A plus C plus D triple therapy regimen. Steps 2 and 3 build a cumulative pharmacological block. Clinicians must exhaust this sequence before clinical resistance can be declared. NICE defines resistant hypertension as blood pressure that remains uncontrolled despite the patient taking optimal doses of 3 concurrent drugs. Before prescribing a fourth agent, the clinician must confirm the blood pressure with an ambulatory reading, assess for postural hypotension, and discuss medication adherence. Once confirmed, Step 4 relies on a deterministic logic gate, the patient's current serum potassium level. If the potassium level is below 4.5 millimoles per liter, the algorithm adds low-dose spironolactone. If the potassium level is 4.5 millimoles per liter or higher, the protocol adds an alpha blocker or a beta blocker. Completing and failing this potassium-calibrated fourth step is the prerequisite for seeking expert specialist advice. The ultimate purpose of carefully navigating this entire treatment algorithm is to successfully reach a specific, age-adjusted blood pressure target. For patients under 80, the goal is a clinic reading of 140/90 or an ambulatory target of 135/85. For those over 80, targets adjust to 150/90 in clinic and 145/85 ambulatory. The NICE framework is a closed loop. It begins with ambulatory staging, moves through demographic initiation, and follows the A, C, and D escalation sequence. Bypassing any step in the sequence introduces clinical risk. Deviating from the flow can lead to unnecessary side effects, overtreatment, or reduced efficacy, based on the patient's age and origin. The 2019 NICE guideline organizes hypertension management into a sequence of decisions based on clinical measurements and demographic data. Following this precise algorithmic structure ensures that every single treatment is directly calibrated to the patient's specific physiological needs.